Now coming to the COPD pathology, cigarette smoking is definitely one of the cause, and because of that, you see smokers who have a history of maybe smoking maybe 1 2 3 sticks per day, but that builds up over a period of time, and because of that chronic inflammation sets in, and that leads to narrowing, destruction of the alveoli. There is air trapping, and there is basically a ball wall mechanism that sets into the COPD. There can be also a genetic cause of COPD when there is alpha 1 antitrypsin deficiency, and the protease enzyme which is there is deficiency. Because of that protease activity, because of that anti-proteases activity is not being there. So again, if this COPD sets in, again airway fibrosis, narrowing, alveolar wall destruction, goblet cell hyperplasia. So of course, even the hyperplasia can occur in bronchial asthma also, but alveolar wall destruction, fibrosis of the airway, and more of the narrowing is more seen in comparatively to the COPD as compared to asthma. And one of the important clinical factor is poor responsive to bronchodilators when we perform a spirometry. So the patient can either be a type 1 respiratory failure, maybe a hypoxia, maybe a hypercapnia, type 2 respiratory failure, or it can be a club of it. But mostly in a patient of COPD, you will see a patient comes to you in type 2 respiratory failure, that is a hypercapnic state, and a bronchial asthma exacerbation will present to you in a hypoxic state. So when we talk about the clinical presentations, most of them can present with chronic cough, wheezing, shortness of breath, especially on exacerbation, but recurrent lower respiratory tract infections are more in COPD as compared to asthma. Variability in symptom severity, like there is diurnal variation, especially if you see a patient of asthma, there is morning, nasal congestion, stuffiness, and with every, in winter season, in rainy season, the symptoms are more flared up. That is not being seen in COPD as compared to the asthma.